pleasure to be here and to follow a very honored talk before me. I must make an excuse, Stuart Campbell, that I will not mention the uterine artery at all in my talk, but it is also to me a very important vessel. I'm coming from Bergen, and I have one particular point I would like to point out to you. That is, I have in a few years been lucky to have a group of people around me who are looking not only to images but also behind the images to try to understand physiology, which makes us a bit more happy about understanding what we are doing in fetal medicine. So that group I have to refer to it repeatedly because much of what has been presented from my group has been done by them. Let us go straight to the heart of the problem. This is umbilical artery, as you all recognize, with an absent diastolic velocity, which says that this is identified already as a poor prognosis. This is a lady who had lupus anticoagulans and had repeatedly miscarriages. So you don't start the surveillance at 24 weeks, do you? But we had the agreement that there is nothing we can do until you reach 24 weeks. So that's the point when she came here now. But we had, of course, at the early stage of pregnancy, dated her because we would like to have a very accurate dating to look at the pregnancy gestational age as it went on and growth. But this lady was also examined at 18 weeks, and then the umbilical artery was like this. So you see there has been, in this 5 weeks, there has been quite a development to the worse, because the umbilical artery at 18 weeks was completely normal. Well, you look at the middle cerebral artery as well, and you see this is also very pathological because there is very high velocity during the diastole, and the pulsatility index is low. So the baby is already very much compensating at 24 weeks or 23.5 as it is. 5 weeks earlier, completely unaffected. We use also the ductus venosus, and you see there is an increased pulsatility during the atrial contraction wave, which is almost reaching the zero line, not yet, but almost reaching. And again, at 18 weeks, this is a completely normal pulsatility for 18 weeks. What do we do with this then? Well, we say you have a baby which is now below 400 grams of weight. We are not in this situation that we are going to have a good prognosis for this. But we made the agreement because that was the way, the protocol in my hospital at that time was that you must reach 26 weeks. Nowadays it's 25, but at that time it was 26 weeks if we are going to do a cesarean section at all. Maybe your baby has to be alive then, and the weight should preferably have reached 400 grams. If that is the case, in our setting, the prognosis is then quite good. We waited then until 25 weeks. Well, the umbilical artery wasn't improving, of course, but the ductus venosus, you see here, was deteriorating. The deterioration is such that you can see there is also an increased pulse. This is the systole, this is the diastolic filling, and this is the active filling of the heart during the atrial contraction wave. Now you see there is a dichotomy between the systole and the diastole, which is deepening here. Why is this coming? This is coming because the heart is stiffer and stiffer, more and more acidotic, less and less compliant. So whenever the heart starts to fill, the velocity increases, filling up the atrium. As the blood hits the atrium and distends, it quickly increases the pressure because the compliance is so small, it is so stiff. The velocity goes sharply down. And that's what you see here, sharp down here. It's not a good sign, it is rather ominous sign. And it can get even worse than this. But this tells us that this baby is pre-terminal. We didn't manage to salvage this baby because it died before it was 26 weeks. But this kind of study, of course, lends itself to longitudinal surveillance. And that's the reason why Cortejo, who is also here, and other groups, 3 other groups at the time, had done longitudinal study to see how these vessels developed. They could see that the umbilical artery at the early stage already were standard deviations away, because that's 6 standard deviations up here and minus 6 standard deviations up down here. And you see that the umbilical artery already 5 weeks before it was delivered, the baby, in many cases was already out of normal ranges. The middle cerebral artery also reacted at the early stage, whereas the short time variation and the ductus venosus pulsatility came late. So using this kind of pattern, we are able to follow the pregnancy and to make a decision when to deliver. We don't know yet what is the best to deliver. If we wait for a long time, you get more intrauterine death, as I got, with the one dying before 26 weeks. If we deliver earlier, you get less intrauterine death and you get more postnatal deaths, as the GRID study has shown. I would like to ask you a question, because when we are doing longitudinal studies, we have a term called conditioning. And I would like to ask you now, is adjusting the prediction ranges according to maternal fetal factors, is that conditioning? You have to answer yes or no. Is 4 is it hasn't finished yet? Okay. So that is 79% thinks that it's according to maternal fetal factors conditioning. That's good, because then we have something to learn. When we are doing longitudinal studies, I think you are more familiar with growth than you are with Doppler. And the principle is just the same. So to make it more understandable, we'll take it from growth. If you, at 28 weeks of gestational age, you make a measurement, and you find that the baby is 1,000 grams, that's 2.5 centile. It's a small baby, isn't it? Okay. So what would you think then if you say, well, you have to come back after 2 weeks and we'll measure, and if you then end up again after 2 weeks on the 2.5 centile, then you follow your trajectory, isn't that so? That's how the concept easily goes, or at least how we like to go. So after 2 weeks, it comes back, it's 1,270 grams, exactly under 2.5 centile. Now we have made 2 cross-sectional independent measurements, and it's on the centiles. This is 2.5 centiles of the entire population. But if you take into consideration that this baby was already measured before and was on a 2.5 centile, you don't expect, if you have 100 babies of 1,000 grams, to grow like the entire population grows. So you construct the expected centiles for those who are normally 2.5 centiles or 1,000 grams. And they will have this range to be expected within. And the 2.5 centile for this population is the 15th centile. If it is a normal patient, if it is a normal baby. We are not talking about pathology at all. This is normal growth. So if I know that this baby was small when it started, you expect that growth to have a different reference range. And that individual reference range you can construct. That is conditioning. So to condition means you condition on the previous measurement or the first measurement, because you can have the first measurement in 24 weeks and you can then condition all the rest of the pregnancy. The 2.5 centile will be down here. So if you are going to do a correct assessment of growth, you'll have to take this into consideration if you want to do serial measurements. Otherwise, you just do one measurement and then another one, and you forget about the previous one, and you do another cross-sectional comparing to the entire population, and another one comparing to the entire population. But then it is no longer longitudinal surveillance or serial measurements. That's how we expect this baby, if it is a normal 1,000-gram baby at 28 weeks, to grow. Within these ranges, you see they go very much parallel to the 50th centile. They are narrower and they are skewed to one side, to the side where the baby is. This is to follow longitudinally in growth. And the same applies to doppler. You have to take into account the population variation. Yes, that is taken into account. You have to take into account the measurement error is also taken into account, is another factor. And you have to express the individual normal development. So that's what it does. Now we are into doppler, of course. So if you take this and you say, well, I have a measurement, sorry, something went, yes. I have another question, by the way. Longitudinal reference ranges can be used both for single and serial measurements. Is it correct? No, you have to vote. Can I use this both, a longitudinal reference range, can I use this for serial measurements and for cross-sectional? No, another point to learn. It's good, isn't it? Okay, you can. And, but you cannot do the opposite. You cannot use cross-sectional reference ranges for longitudinal surveillance. But you can use longitudinal surveillance reference ranges, provided they are well done, appropriately done. You can use them for both, for anything. Now, we had the patients with a pulsatility which were in the upper range here. 137 in the pulsatility, so that's the 97.5 centile. So we are again in the same situation as when we were with growth. We want her to come back. And then, well, the development in the vasculature follows much the same system as it does in growth, of course. There is a development, and you have to take into account the specific development of the vasculature. And that is done when you're doing the longitudinal study. So in this case, if you do the conditioning from the previous measurement, that's the range you would like to have. And the 97.5 centile is up here. If you had just been eyeballing when you had been doing first the one measurement, and then after 2 weeks you saw another measurement coming up here, you would say, well, it is a worsening. Is it? Well, if this was a small baby in the first hand, the small babies, they will, at average, have a higher pulsatility in the umbilical artery because they have a smaller placenta. That's normal. And the big babies, they will have a bigger placenta, and they will have the pulsatility range more to the lower portion of the population. So this is conditioning now for this baby. And this is the expectation ranges if you count from the 97.5 centile to the 2.5 centile. When I am here, there is a 50% possibility that the baby will score within this range from here and up here. But I expect still that there is 50% possibility even to be below that. So this also tells me something about the error or the system of what I'm doing. So you see, when I'm conditioning now, the ranges hasn't become much smaller. The ranges is almost the same as this here, as the entire population, but skewed slightly to one side. The reason for that is that the individual variation is big, the error of the measurement is also included, and when you take all this into account, conditioning for this isn't changing it very much, but it is shifting it. We have spoken about the ductus venosus. This is the normal ranges for the ductus venosus. Another one which you are very interested to use for surveillance, particularly if you want to decide the date or the time of delivery. Because the ductus venosus, compared to the umbilical artery, it's much more instantaneously telling you what's going on. And the risk is also that it is instantaneously telling you what is going on at the moment, which is normal and abnormal. So if the baby is jogging, you will see the ductus venosus change. So we have then got in our clinic a patient where the ductus venosus pulsatility is above 90 centile when it comes into surveillance with us. We condition it, and you see this is the 90 and the 10th centile for this, and then we follow it for 2 weeks, and then it ends up here, and then we say this is enough, and we deliver the baby. Again, shifted, but not much reduced. And you will understand that when you look at the individual variation through pregnancy. It's almost chaotic. This is the longitudinal, each of those normal pregnancies which were included when we were making our reference ranges. And you see it bumps up and down enormously. And because there is such an enormous variation individually, then the ranges will not be much changed. But it's quite useful to know these kind of things, because when you are studying your Doppler, you should be aware of what are you actually looking at and how are you going to interpret it. We have something called the middle cerebral artery, or if you like, you can make a ratio with the placental ratio, the umbilical artery, as Christoph Brzezinska commonly has advocated previously, and that's quite a useful thing. We had a small baby. It was down here with this ratio, and then we conditioned it. And you see the ranges that we expect this to develop along. And it's not much different from the rest of the population, again, because the variation is so big. What kind of reference ranges would you like to use? There are numerous reference ranges out there, and you will have to decide which one you are going to use, and you would like to use the best one. There are certain criteria you will have to look for to decide which one you would like to use. One is that there is a sufficient number of individuals included. And to make good reference ranges, usually you will need at least 15 observations per week. And how do you know then that this is a reliable thing? Well, once you have constructed the reference ranges, you ask for the 95% confidence intervals for those ranges. You are not so interested in the mean. You are much more interested in the limits where you are going to decide whether this is outside it or inside. And then you see that this 95% confidence limits here tells you that if you do this study once more, you will have pretty stable, they will be with 95% probability within these limits for the next time. So you would like to have them to tell what are the 95 confidence limits for your ranges. So you will have to have a decent number included, and it has to be prospectively done, and it has to be done on patients or low-risk patients or low-risk participants, rather, to make it good. Then you will get reliable ranges, and then you can calculate your individual terms, which always should be there in addition. So this brings me to the point that there are reference ranges based on sufficiently large numbers. Are the extreme values reliable? Is the study population reflecting the background population? You have to look at how were these babies when they were delivered. Is that comparable to your low-risk population? For the serial measurements, is the longitudinal design there? And that means, can you calculate conditional ranges? Take care to use the same technique that they used when they were doing the doppler. Because if you use different techniques, as we have seen from Christoph, you can vary very much. So you have to be very attentive when you are working with the doppler to use the technique as it was recommended or according to the reference ranges. Check how your measurements actually are distributed compared to the reference ranges. You should have some kind of checking that you are really doing the right things. So, could I ask again? Conditioning is adjusting the prediction ranges according to maternal and fetal factors? Well, you have to vote. Yes, there is a change at least. Just to make the point quite clear, this is not conditioning, this is customization. That's what Jason Gardossi is doing. Then you take into account ethnicity, fetal sex, and so on. That is customization. Conditioning is what we are doing when we are calculating according to the previous measurement. Yes. And the next question we had, longitudinal reference ranges can be used for both single and serial measurements. I think that's clear by now, isn't it? We are at the moment working with longitudinal study for the uterine artery in the same way. So this is greatly improved. Thank you very much.